established back in 2013. I started working in a clinical commissioning group. So I've been in the NHS for quite a while. I've been a commissioner side. Never been in a provider, but for the last 20 odd years, I've been supporting primary care and working with practices and the side of finance that is linked very closely to practices. In Leicestershire, we've got 133 practices. We've got 20 that form 25 PCNs. We've got a list number of patients. Our practices vary from the largest, which is has over 35,000 patients, and that covers the bulk of one of our market towns, Melton Mowbray, in the sort of east of Leicestershire. Down single-handed practices across the city, mainly we've got one or two that are around 1,300 patients, so a single GP looking after 1,300 patients in the city is the smallest. Our allocation, our total budget for the system, so that covers secondary care as well as primary care, is 1.8 billion in 21-22, and primary care makes up around 378 million of that. So that covers things like prescribing and the primary care contract, so we'll go through that in a bit more detail in a bit. So this is the introduction screen. So we'll talk through all these different headings throughout the course of the next 45 minutes ish. So we'll go through each of those headings in a bit more detail. So hopefully you'll learn a bit about general practice funding, but also hopefully you'll learn a few snippets about the place where I live, Leicester, and our Leicestershire and Rutland. So hopefully it'll be quite informative for you all. If we could do we'll do questions at the end, I think. We'll tackle those at the end, so because I can't see any hands at the moment, but anyway, we'll kick off. So the first section is around the core contract. So general practice contractors are split into three types of contract. By far the most popular is the general medical services contract, which covers around 70% of the practices across the country. These are the standard contract that was nationally agreed back in 2004. The payments are based on a list-based approach. So there's what we call a Carhill weighted formula, and that basically takes their raw list size. So each patient will be one patient on the list size, and then it weights the patients depending on their particular circumstances and demographic. So age, sex, and market forces are taken into account. The patient's morbidity and mortality is also in account, as well as a residential home. How rural the practice is, because obviously a rural practice would have different needs to a city practice, particularly when it comes to home visits. So obviously a lot more time spent on the road visiting the more rural areas of the county and the footprint of the practice boundary. And there's also a recognition of list turnover rate. So if a practice, for example, may be a university practice, may see a large influx of patients at a particular point in the year, then they are that's taken into account when working out their Carhill weighted list size. For this year, 21-22, the value per patient is £97.28, and that's So that's for the whole year. That's paid monthly to the practice with quarterly list size adjustments. So as the practice list changes, obviously throughout the year, patients will leave the list and or join the list. There are 4 points in the year when the list size is reviewed, 1st of January, 1st of April, etc. And then the payments are adjusted to reflect that new list size. So practices will see an increase in their income from their core contract if their practice list sizes increase, and that, as I say, takes place on a quarterly basis. The main GMS contract is for the provision of essential services. So these are mandatory for registered patients and temporary residents, and has a broad sort of objective of the identification and management of illness, providing health advice and referral to other services where necessary. They are contracted to provide core service for core hours. So this is 8 a.m. to 6:30 p.m. Monday to Friday, excluding bank holidays. So that's what the GMS contract covers. There are a couple of elements that they can opt out of, and the majority of practices opt out of out of hours. So prior to the 2004 implementation of this contract, practices were responsible for providing an out of hours service. So that's evenings and weekends and bank holidays. But there was an option in the agreement that they could opt out of hours, but by doing so, they would surrender part of their payment, their core global sum payment, that 97.28. This year that opt out cost them 4.75% of the 97.28. So in effect, they get paid £92.69 for each patient for 21-22. Each year that value changes, obviously with inflation and other pressures. The BMA and the NHS have discussions and negotiations, and then around the end of March they publish their new rates, and generally the opt-out percentage also changes as well. So it just adjust every year. So that's the general medical services contract. And then there are another couple of different contracts. There's the personal medical services contract. This is agreed locally. It's more flexible and tailored to local needs of the population, but it is actually being phased out. 26% of practices hold a PMS contract across the country, and they tend to be sort of more quality based. So those are a bit more straightforward, a local agreement around the value of the contract and targets, etc., quality targets, outcomes, those sort of things will be built into the contract. And then there's the other major sort of contract is the alternative provider of medical services. This is a PMS contract. It gives greater flexibility and is open to other providers, so private providers or third sector bodies. We've got community interest companies that are holders of APMS contracts. They are time limited, so generally around 5 years with a possible 5-year extension, so that practices or the providers can plan a bit for a long-term period. And they generally cover specific cohorts of patient, or can do. Then we've got the homeless patients or asylum seekers, for example. Sorry, there are a couple of people waiting, I think. could you go on mute, please?
Okay, it's just whether because you put it as low.
Could I ask people to go on mute, please? There's some background noise. Okay, thank you. So practices are generally the vast majority of the GMS contractors are independent contractors. They work under a partnership model. So partners leave and join throughout the time of the contract. They are open-ended, so they have no end date as such, but they can be handed back by the partners at any time, or they could be or their contract could be removed if, for example, their CQC report isn't, or the CQC decide to cease their registration. So they have to, the CCG then has to provide a caretaking service until alternative provision for those patients are provided or commissioned. Right, so the next. So that's the GMS contract, the core contract. The next slide is around the quality and outcomes framework. So this is an incentive scheme. It's worth around £128,000 to an average practice. It is an optional scheme, but all practices, obviously because of the size of the income, have signed up to this. So it's an incentive scheme that covers the period for the whole 12 months. This year, 21-22, there are 635 points available. Last year it was 567. There are adjustments every year to sort of target particular areas or those areas that are not being dealt with or are new to primary care. For example, it gives them a bit of an incentive to look at those particular cohorts of patients. The QOF point is valued at £201.16 for this year, and the average practice list size is 9,085 for 21-22. So the rate that this is paid is each point is worth £201.16 for a practice with the average list size of that 9,085. If, for example, the practice list size was twice 9,085, then they would, a QOF point would be worth £402.32, for example. And likewise, if you've got a single-handed practice with a practice list size of 1,000, then you get a proportion of the 201. So the value per point changes depending on the size of the practice to recognise the amount of work that's required for each practice, because their cohorts of patients will be different, obviously, and so that's paid. Well, 70% is paid throughout the year, so a monthly value, a monthly amount of 70% of their total, and then the final 30% is paid in June of the following year. So this year, June 22, we'll be paying 21-22's achievement, which tops them up to their final top tally, the quota or the achievement figure. So whatever points they achieve, they'll get paid the top up in June time. It's split into a number of domains. So 401 points cover clinical domains, 160 points cover public health domains, and 74 are cover quality improvement. So things like early cancer diagnosis and care with people with learning disabilities. And then sort of the public health ones are around blood pressure monitoring, obesity, and smoking cessation and screening. So I've put down there in the slide the flu, the different domains, just a sample of the domains that practices are dealing with or providing services that are linked to this incentive scheme. So flu vaccine screening, register maintenance for a number of patient cohorts, various different prescribing indicators, and as I say, the COPD, asthma, heart failure, and those sort of things are all the sort of clinical domains. So that's our quality and outcomes framework, which is a local, a national incentive scheme. The picture on the left-hand side is, or just for your information, really, is right in the centre of Leicester. So there's the clock tower in the background that marks the centre of the city, and the statue on the left is what they call the Sporting Success statue, and was erected in 1998 following a particularly successful year for Leicester and Leicestershire clubs. So a Leicestershire County Cricket Club won the Britannic Assurance County Championship. Leicester City Football Club won the Coca-Cola Cup, and Leicester Tigers won the Pilkington Cup. So it was felt that it would be really good to mark that achievement with a statue. So you can all go and have a look when you're next in Leicester. So that's quality and outcomes framework. Linked to the GMS contract, or the national contract, are a number of enhanced services. These services, there were a lot more than this initially when the contract was first implemented in 2004, because of a technicality, and that the NHSE hold the main contract, and CCGs were commissioning enhanced services. They couldn't be linked directly with the contract. So the two services on the screen, the learning disability health check and the service for deregistered patients, are the only two that continue to be an enhanced service. The rest of the former enhanced services are now community-based services that we'll come to in a minute. But these two services, the LD health check incentivises practices to carry out a health check for patients with learning disability. And then there's the deregistered patients service. So this is a service for patients that have been removed from patients' lists due to one thing or another. They generally have to have a police incident number to be able to be removed from a list. Across Leicestershire, we have a single provider who provides a service for this cohort of patients, and when I last looked, they had 43 patients on their list. They provide the normal core service to these patients, but obviously with a bit more of input in order to keep everybody safe. Yeah, so that's those are the two directed enhanced services commissioned. One of the other main areas of expenditure into primary care, or from the CCG into primary care, is premises funding. So in LLR, £17.5 million worth is paid to practices in relation to their premises funding. So there is a couple of guidance documents. So there's the premises directions for 2013 and the premises directions for 2003, which are used to ascertain whether what the resources to be utilised for and what's appropriate to be reimbursed. So those are two sort of main premises documents that we utilise to refer to. So premises funding is split down into 4 areas. So there's the rates, so non-domestic rates from the local authority. So each practice will obviously receive a non-domestic rate bill from their council. That those are then sent in or paid by the practice, and then sent into NHS to be reimbursed. So there's quite an influx April, May time when the rates bills land on the practices mats. So those are reimbursed. We've got a budget for that. For those, water rates are also reimbursable. That includes the wastewater as well, so clean water and waste. And again, practices submit their water rates bills to the NHS, and then they're reimbursed. The CCG hold the budget, so the costs come through our systems. Clinical waste is also reimbursed. There are various providers of clinical waste collections. A number of those are commissioned directly by the CCG, and we pay those directly. But others, the practice will have a contract with the waste disposal company for collections. They then submit their invoices to the NHS, and the budget again is our budget. The payments are made from our systems. And then there's the rent. So rent is reimbursable. There are different models for property ownership of property, and the way that practices own their or use their properties. So for a property that's owned by the partners, then we have what we call a notional rent payment. So every 3 years, the district valuer commissioned by the NHS will go out to the practice and review the premises and come up with a notional a rent value for the practice, as if it was a rentable property providing primary care services, then that's the basis of the district valuer's valuation. And the CCG then pays the practice for that notional rent value over the course of the 12 months. And as I say, that is reviewed every 3 years, and so it keeps up with inflation changes in the rental market. For properties that are leased by the partners or the practice, then we would, or the CCG would pay the actual rent. So the rental charge that the owner of the property is charging their partnership, we would reimburse. Again, that is subject to evaluation. So it needs to be okayed by the district valuer in order for the CCG to reimburse the practice. And then there are a number of practices. We've got 5 or 6 in Leicester and Leicestershire that are owned by NHS Property Services, and there are practices inhabit various elements of those. It might be shared accommodation with a local community provider, or fully occupied by the general practice, and whatever NHS Property Services charge to the practice, then we would reimburse the rent for those two. So those are, as I say, premises costs, and the premises elements that are sort of pass-through payments to the practice. So the practice incur the costs, but then claim them back from the CCG. And the photograph on the right is a small part of Bradgate Park. Again, in Leicestershire, it's 850 acres of parkland. It was given to the people of Leicester in 1928. And it's famously the home of Lady Jane Grey, who was born in Bradgate House, which is on the site, on the park, in 1537. She was famously the 9-day queen who ruled for 9 days in 1553 and was the granddaughter of Henry VII. It's a really nice place to visit, and gets rammed in the summer when it's really hot. So everybody from Leicester ends up there. Community-based services is next on the list. So as I mentioned this earlier, so these are locally commissioned. They used to be linked to the contract, but no more. These are locally commissioned services to meet local patient need. There are separate agreements for each one, and they could be on a price per activity basis or a block arrangement. And listed there are a number of examples. So we have a minor injury service, near patient testing. This is a service provided to complex drugs that need regular monitoring by general practice, blood tests, things like that. We've got like a sliding scale of amounts. So for the more complex patients that need regular review, there'll be a higher price per patient. Secondary care bloods are just a payment that we make to practices to recognise that some of the blood tests that they're being asked to carry out are instigated by secondary care colleagues. So we're reimbursing or rewarding them for carrying out that service. Travelling families, so we've got a number of practices in the county who have high numbers of travelling families in their patient list. So we're recognising there the work that cohort of patients require. INR monitoring for warfarin patients. So these are patients that are on blood thinning product warfarin. And we commission a service from providers, primary care and federations to provide an INR monitoring service. So patients would be tested on a monthly basis or more frequently if required, in order to make sure that their blood clotting levels are at a target, in the target range, and then they adjust their meds to ensure that they move towards the range if they're not. And also there's the H. pylori breath testing that we also commission from practices. Those are just a few examples, but across the country there are, you know, depending on local need, there'll be a different list in each system. So it just gives you an idea. The next slide would talk about primary care networks. So this is relatively new to primary care. So these were introduced in July 2019. So coming up to 3 years ago. And they are a group of general practices, usually covering a specific geographical area. So we've got 25 in Leicester, Leicestershire and Rutland, although they are going through a bit of a reorganisation at the moment, with us becoming a system, working closer across the 3 former CCGs. So we're going to increase the number of PCNs to 26. Our largest PCN covers a population of over 100,000 patients, and that's the one in northwest Leicestershire. But they typically serve a population of between 30,000 and 50,000 patients. And they were set up really so that practices could be more resilient across an area and could cross cover, for example. So practices within a particular PCN might cover patients from other practices within that PCN. So there's a bit more resilience in primary care. And there's a lot of the new developments are all linked to primary care networks. I don't know whether you've seen the news recently. They are talking about extended hours access and incentivizing PCNs to provide an extended hours service that covers 6:30 to 8 p.m. Monday to Friday and 9 till 5 on a Saturday. The implementation date for that is October 22, so that's just been announced. And to fund that, on my list of payments on there, there's one there for extended hours access, the £1.45. They'll be receiving that £1.45 plus £6 per patient that we've got elsewhere within our budget. So they'll be receiving £7.45 to cover per patient to cover for those extended hours. So there was a bit of discussion about that recently when the letter came out. I think it was earlier this week. No, last week, 1st of March. So so that's extended hours. So primary care network members all receive a participation payment on a monthly basis to incentivize them to stay within the PCN and communicate and take part, etc. And then primary care networks receive a number of support elements of support. So each one has a clinical director that is a GP within the PCN, and we cover 0.25 whole-time equivalent of their costs. So we're paying the PCN to cover a quarter of their time. Each PCN gets a core primary care network payment of £1.50 per patient per annum. As I mentioned, there's the extended hours access that's changing. So the whole 745 will go into PCNs to provide that service. There's the Investment and Impact Fund, which is similar to the Quality and Outcomes Framework, but it's for the PCN. So it's currently this year there's £150 million going into the IIF, and it with the triple aim of improving health and saving lives. For example, with the uptake of flu vaccinations, improving the quality of care for people with multimorbidities, with the use of people like social prescribing link workers. I'll talk about them in a minute. And helping to make the third aim is helping to make the NHS more sustainable. So there are a number of domains that are included in the IIF. So there's the prevention and tackling health inequalities. This includes vaccinations and immunisations, cardiovascular disease prevention, and personalised care. There's providing high quality care, so with access or enhanced healthcare in health in care homes. And then the sustainable NHS is another major domain within the IIF. So there are, well, currently 666 points. The value per point is £200. And again, it's similar to the QOF in that it's flexed depending on the size of the PCN. So £200 per point is for the average PCN of 48,000 patients. Our funding within LLR is about 1.1 million. So not a small amount. So that's the investment and impact fund. And that changes every year. A number of the points have been stood down this year because of the ongoing COVID issue. So practices can concentrate on vaccinations, etc. So some of the points have been repurposed and payments made to the practices in different ways, just to support practice, general practice this year. We're not sure how many points will be available next year, but it'll probably be around the 600 mark. There's PCN development funding as well, that's on the list. So I think this year we've got about 540,000 to share with PCNs. They've all submitted their plans on how they're going to achieve their various targets, improving patient care, etc., and working together. So we've paid that out to our 25 PCNs. And then one of the major elements of the introduction of the PCNs was the additional roles reimbursement scheme, or ARS. This relates to workforce, as it suggests. So it was a way of getting workers, primary care workforce bolstered in order to deal with patients and to remove some of the pressure off primary care GPs. So when the roles were first introduced, there were 2 roles on the list that most practices went, or most PCNs went for. There's the social prescribing link worker and community pharmacists. So obviously community pharmacists can help with checking prescriptions, drug reconciliations with patients who are discharged from secondary care. Social prescribing link workers are there to sort of signpost patients to different services in order to improve their health and well-being. And there's been quite an uptake of those over the past couple of years. The list on this second, this is the list of the additional roles that practices can claim for. For each role, there is a maximum amount reimbursable. So as you can see, and the grades are on there as well. This will be amended for 22-23. So clinical pharmacists, for example, PCNs can employ those, and we will reimburse up to a maximum of 57,318. As you can see, there's quite a number of different roles that are included in the scheme. And we have got all our PCNs are now claiming. There are a number of roles that we haven't got any of the claims for as yet. And I say most of them are clinical pharmacists or social prescribing link workers. There's a few physician associates that can also support general practitioners and nurse associates. And then there's there's a number of community paramedics as well, who are employed within primary care networks. For the bottom 2, so the adult mental health practitioner and the children and young people's mental health practitioner, we are reimbursing them for 50. Well, the individuals are employed by the local community trust, mental health community trust, and the PCNs take 50% of their time. So we reimburse the PCNs for those costs. So working closely with the local provider of mental health services. There's 1 or 2 of those out in our 25 PCNs that we claim for. The budget for the annual additional roles this year is 13.7 million, so a significant amount of resource going into primary care in Leicestershire to cover roles. We're forecast to spend 11.5 million, so just a couple of million short, but it's as you can imagine, it's from a 0 start in July 2019, and each year the budget is increased significantly. So I think the budget goes up by about 20% next year. So all PCNs are now working on their plans and recruiting for 22-23. The latest report that I've seen indicates that there are 258 whole-time equivalents working across Leicestershire that we didn't have, that primary care didn't have funding for previously. So that's 258 more whole-time equivalents in primary care supporting general practice. So that's additional roles. The final slide before the questions is around other payments that are made or can be claimed by primary care. So locum costs are reclaimable. So if a practice has a GP, a salaried GP or a partner on maternity, paternity sickness, or is suspended, then the PCN, the CCG would reimburse part of their costs. So, for example, for the first 2 weeks of maternity, they're able to claim just over £1,100 to cover the locum costs, and then that rises to £1,750 from week 3 onwards. That's the same amount for sickness after the first 2 weeks, and for a suspended GP, we cover the first £1,100 of their cost per week. That obviously doesn't cover the whole of their costs that the practices are incurring, but it goes towards them covering the sessions that those partners are not available for. And that's a claims processed, so they send in claims on a monthly basis, and the CCG then reimburses for those. Another area that the NHS pays is for the syringes and needles, so that are utilised in primary care. So those are purchased locally and distributed to the practices. General practice information and technology. So most of the kit that practices use is owned or provided by the NHS. We have like a rolling replacement programme. We use capital resource available from NHS England. We have a programme of replacing kit every 3 years, and so that's an ongoing programme, and it's then reimbursed and by NHSE and goes on to their register, capital register. Their systems are all provided by the NHS. So most of the practices are on System 1 or EMIS Web. There's support provided by the NHS on those systems. We don't, however, support things like business software. So each practice is obviously an independent contractor, a small business, or a CIC or a limited company, and they provide that and use that software themselves. We provide the clinical software. So that's information technology. Prescribing fees and drugs costs, I put that on there just to as a bit of a prompt, really. So prescribing fees are a payment made to practices based on the number of prescriptions issued. They go directly to the practice. And then there's the drug costs. So the cost of the drugs that are on those prescriptions, the budget for those, again, is held by the CCG. So this year, our drugs budget is around 379 million. So those costs come through from once the prescriptions are processed by the Prescription Pricing Authority up in Newcastle. Their costs are all worked out and then taken from our resource sort of a top slice. So we're monitoring the budget all the time. It's obviously really difficult to monitor because we don't have an awful lot of input into the drugs that the practitioners prescribe. We do have some incentives to get them to prescribe one drug over another. But yeah, it is quite a difficult job to try and forecast spend on on drugs. Another thing that is reimbursable are the Care Quality Commission fees that practices receive. A bill every year to be as part of the CQC. Again, they submit those invoices and we then reimburse them. There's a couple of areas that practices receive funding that are outside of clinical commissioning groups. So NHS EI commissions services. So they commission the immunisation and vaccination programmes. So the flu vax and the COVID-19 vaccination. So for example, for a COVID-19 vaccination, they get £12.58 per vaccination. That's the base rate. There was a number of adjustments to that over Christmas and for various cohorts. So there was extra £10 here and there for one or two of the different cohorts or timings to recognise the out of hours bit when there was a big push. The flu vaccination, I think, is just over £10 a vaccine, so that they're all paid on items of service. I think they claim those monthly. The other quite significant area for for training practices is support for trainee GPs, so that the NHSEI would pay training practices to provide a training service. So these are generally the larger practices that can support trainees. We don't get involved with those at CCG. And then there's the final elements of the public health services. So these are commissioned by the local authority. So contraceptive services, so IUCDs, etc. Smoking cessation services and drugs misuse, they're all commissioned by the local authority. And I think when I last looked, I think they were paying them on activity. So they were submitting quarterly claims and then the local authority makes the payments. So that's the complete presentation. There are a couple of documents. I mentioned one of them already. There's the premises cost directions, but there's also the statement of financial entitlements that's updated annually, and that provides that's really the Bible that we go to that details, what the new global sum rates are, QOF rates, the different domains, etc. So if anybody's interested, those are the two documents that you need to dig out and have a look at. So that's basically my presentation. So thank you all. I'll stop sharing my screen. Does anybody have any questions? Mark, do you want to come in?
Hi.
Hi.
So I've not met you before, but I'm Mark Farmer. I happen to be in Leicestershire and work within the local system. So
Right.
Nice to meet you. Just a few quick questions I had. One was around kind of investment into practices they're building, because I know in LLR we have some very old-fashioned buildings that GPs use. And I'm just wondering what funding there was there and how they are funded to address that. the other question I had was about population growth, because obviously in Leicestershire we've got huge amounts of house building going on, which is putting pressure on certain practices.
Yeah.
And I'm just wondering again where the funding comes from to address that. And my final point really is, as we move towards tackling health inequality, as all ICSs will be obligated to do so, what are you seeing around kind of GP patients that might, sorry, GP payments that might potentially change to address that more?
Okay. The first point then, premises funding. So in LLR, we've recently produced a primary care estate strategy. So they've looked at all the primary care estates. So each practice is included on there. And if a number of practices have branch surgeries, so if they've got a population, a small population elsewhere, then they'll have a branch as well. So in another neighbouring village or, you know, down the road. So all those sites are taken into account, and the estate strategy has attempted to rank the practices, use things like practice list growth, future list growth, developments in the area, you know, that sort of thing, and the state of the property at the moment. So we have got, as you say, Mark, there are a number of practices that are in substandard sites that are towards the top of the list. We haven't, well, there isn't any capital funding at the moment. We've had estates and technology transformation funding in the past, which was held by NHS that we could claim upon, but that's reaching its, and that was like a 5-year program. That finishes in March. So, and there's no indication of whether that ETTF funding will be available or anything similar will be available from 22-23 onwards. And that funding in the past has been used to support practice development. So we've had some major extensions put on a number of practices using ETTF. And so, you know, it's a real shame that we've not been able to, or there's no indication of whether that funding will continue. So that we have got the estate strategy. Your second point around population growth. So when a developer builds a new estate, or like on the outskirts of Leicester, they're building, can't remember what it's called, just on the side of the motorway, M1 junction 21A, Lubbersthorpe, New Lubbersthorpe, I think it's called. So major urban development. The developers, as part of their planning permission, will provide what they call Section 106 funding. And this is funding to support the community, and health has a call upon that funding. So generally, if a practice is on the list of priorities, then we would look at whether there's any Section 106 funding available in that local area. It's held by the local authority until till the buildings are completed, and then we can use that to support new practice or extension to an existing practice. That's the only funding we have at the moment that's linked to developments for capital. Other areas, some areas have a community interest levy or community investment levy, I think it's called, that Leicester City Council have, but it's generally more difficult to obtain that, we've found, although we're trying to access it. Your final point, Mark, is around tackling health inequalities, and I think the link to the IIF, you know, that tries to deal with health inequalities, and things like the quality and outcomes framework, as I said on the presentation, that the QOF points do change every year, and you know, if there were issues around inequalities, then they would be dealt with nationally through that process. So I hope that enlightens you a bit more. Yeah, and as part of the system, you know, we're always looking at health inequalities and trying to tackle them as a system, as you know, as part of Leicestershire Partnership Trust. So thank you for your question. Is that okay? Thank you. Does anybody else have any questions before we finish? I've looked at the chat there now. Let me just check the chat. Just a point about ABRA, your question around funding. So the Statement of Financial Entitlements is a public document. You can do an FOI, and I'm just trying to think. You could work out what their income is from their global sum, from their list size. But obviously we don't know all of their practice income. They are independent contractors. So I've just gone through the bits that I'm aware of from the NHS, but then on top of that, there would be some private income for things like insurance claims, health checks, private health checks. But I think there is a requirement for practices to publish some earnings information on their website. I think that's being pushed up the agenda a little bit. Thank you. Are there any further questions? I hope you found that really useful. As Becky said, the slides will be shared with you. And if you've got any questions, I'm Andrew Roberts, andrew.roberts8@nhs.net. You can contact me on the email. Thank you very much for joining me today. Hope you found it useful. Thanks, Adam.
Thank you.